You know the drill, right? I mean, the trees are blooming, the air is just thick with pollen, and your nose is running like a broken faucet.
Oh, yeah. It's miserable.
Right. So you do what you probably always do. You just blindly reach into the medicine cabinet for that tiny allergy pill. You pop it, wait 20 minutes, and, expect your biology to just sort itself out.
Which is such an automatic reflex for millions of people.
Yeah.
You feel that tickle in your throat, the pressure in your sinuses, and you just want it to stop so you can get on with your day.
Exactly. But looking through our stack of sources for today's deep dive, and we've got everything from contemporary pharmacological journals to historical archives from the Pasteur Institute, it turns out that Tiny Pill represents a century-long saga.
Yeah, a really messy saga, honestly.
Totally. We're talking accidental discoveries, Nobel Prizes, and frankly, a fundamental misunderstanding of how our own cells actually function.
Because the scientific record here, it's really a masterclass in how pharmacology has to constantly course correct. I mean, the mechanism we thought was driving allergy relief for the better part of the 20th century, it turned out to be completely inaccurate.
And that's our mission today. We are unpacking the actual science of antihistamines. We're going to explore how pharmacologists had to completely rewrite the definition of this drug twice, uncover the biological mechanics separating the first and second generations of these meds, and look at the hidden life of your cell receptors.
Which is staggering when you get into it.
It really is. But to get into it, we have to start with the target itself, right? Histamine. At its most basic level, it's just an inflammatory signaling molecule.
It is, yeah.
Yeah.
But it's actually really helpful to think of histamine as a sort of biological multi-tool.
Okay, a multi-tool.
Right, because the immune system uses it to trigger inflammatory cascades during an allergic reaction, sure. But the body also deploys it for entirely different tasks, like stimulating gastric acid secretion in the stomach.
Wait, really?
Yeah.
Stomach acid.
Yeah. And it even acts as a central neurotransmitter to regulate arousal and wakefulness in the brain.
Wow, okay. Which brings us to the first major misconception, I think. Because if I take an allergy pill to stop that inflammatory signaling, the classic model I have in my head is a competitive antagonist.
Right, the old standard model.
Yeah, like I'm picturing a bottle and the histamine is trying to get inside. The allergy pill acts as a cork. You shove the cork into the bottle. The histamine is physically blocked from entering and the reaction just stops.
And that cork in the bottle model is exactly what the scientific community operated on for decades.
But it's wrong.
It's deeply flawed. The contemporary pharmacological journals in our stack show that the breakthrough that finally shattered this assumption didn't even arrive until the late 1990s.
Which really wasn't that long ago.
Not at all. And it happened when researchers developed a better understanding of G protein-coupled receptors, or GPCRs.
Okay, so the histamine receptors in our body, specifically the H1 receptors that handle the allergy symptoms, those are GPCRs. But I'm struggling to understand why the cork analogy fails. I mean, if the drug is sitting in the receptor, isn't it blocking the histamine?
Well, it is blocking the histamine, but the receptor itself isn't a passive, empty bottle.
Okay.
GPCRs are these really dynamic proteins. They exist in a state of thermodynamic equilibrium. So they're constantly shifting between an active shape and an inactive shape.
Like moving back and forth.
Exactly. And what researchers discovered is that these H1 receptors have a really high level of basal or constitutive activity.
Meaning what, exactly?
Meaning, even when you are living in a completely sterile environment with absolutely zero histamine present in your system, these receptors are spontaneously flickering on and off.
Wait, so even without a trigger, the receptor is just firing on its own?
Yep. They're constantly generating a low-level baseline of cellular signaling.
That seems biologically wasteful. Why would a cell have an alarm system that occasionally just rings for no reason?
Well, it's less of a false alarm and more about maintaining physiological readiness, right? What we call basal tone. The body often keeps systems slightly primed so they can respond instantly to a genuine threat.
Ah, I see.
But this flickering, this is the death knell for the pure antagonist theory. Because if an antihistamine were just a passive cork, it would stop new histamine from binding, sure, but it would do absolutely nothing to stop that internal spontaneous flickering.
Oh, because the receptor is still turning itself on.
Exactly. The receptor would still be partially active, and you'd still have baseline inflammation.
And what is the drug actually doing if it's not just plugging a hole?
It acts as an inverse agonist.
An inverse agonist.
Right. So when the drug molecule encounters the H1 receptor, it doesn't just passively sit there. It has a very high structural affinity for the receptor's inactive conformation.
Okay, so it prefers the off shape.
Yes. And by binding to the receptor while it's in that off state, the drug effectively locks it into place. It actively suppresses that spontaneous flickering, and it drags the entire thermodynamic equilibrium of your cells into an inactive state.
So it's like it's reaching into the machinery of the cell and forcibly throwing the power switch to the off position. It's overriding the body's natural baseline.
That's a much, much more accurate visualization, yeah.
Yes.
And discovering this inverse agonism was a massive paradigm shift. I mean, it forced pharmacologists to completely rewrite how they classified the medication.
But that was only one of the major redefinitions, right? Because discovering the H1 receptor inherently implied the existence of others.
Exactly. It's not just one type of receptor.
Right. Our sources outline 4 distinct receptor types that histamine acts on. There's H1, H2, H3, and H4. And we know the H1 receptors are located in the blood vessels, smooth muscle, and nerve endings.
Yeah, those are the ones driving the hives, the swelling, the itchy eyes.
Right.
And because they target different tissues, the architecture of the receptors varies. Like, the binding pocket of an H1 receptor has a completely different arrangement of amino acids than an H2 receptor.
But histamine fits in all of them.
It does. Histamine is a very small, highly flexible molecule, so it can bend and fold to fit into all of them. But the synthetic drugs we design, those are rigid.
Okay.
They're engineered to fit precisely into one specific receptor pocket and just ignore the others entirely.
Which leads to a really counterintuitive realization in the data, because if H2 receptors exist and drugs are designed to block them,
Yes.
that means medications like famotidine, which most people know as Pepcid, or the discontinued ranitidine, known as Zantac, those are H2 blockers. So are heartburn medications technically an antihistamines too?
Chemically and biologically, they absolutely are.
That is wild. I mean, nobody thinks of grabbing an allergy pill to treat a stomach ulcer.
No, of course not. But that's because H2 receptors are highly concentrated in the parietal cells of the stomach lining. Their specific job, when they're stimulated by histamine, is to pump out gastric acid.
Oh, I see.
So when you take an H2 inverse agonist, like Pepcid, you are locking down the receptors in your stomach, which suppresses the acid production. But it does absolutely nothing for the H1 receptors in your nasal passages.
Which means the word antihistamine, at least as we use it in daily life, is basically just a cultural shorthand.
Pretty much. Yeah.
Like when a commercial says antihistamine, they specifically mean an H1 inverse agonist. But biologically speaking, Pepcid and Benadryl are essentially chemical cousins doing the exact same job, just in different cellular neighborhoods.
That's a great way to put it. And identifying those different neighborhoods was not a clean or linear process.
No, not at all.
To understand how we actually engineered these highly specific inverse agonists, we really have to look at the somewhat chaotic history of how they were discovered in the first place.
Yeah, let's pull from the historical archives in our stack for this, because it goes back over a century, right to 1910. The British physiologists Henry Dale and Patrick Laidlaw were the first to isolate histamine. And our sources note they were extracting it from ergot, which is a type of fungus, and they were testing it on animals. And they were completely shocked by the physiological response.
Yeah, they observed that injecting this isolated molecule triggered immediate, basically catastrophic shock in the animals.
Like an allergic reaction.
Exactly. Profound drops in blood pressure, smooth muscle contraction, severe respiratory distress. Dale and Laidlaw realized they were watching a chemically induced anaphylactic reaction.
Wow.
It was really the first concrete evidence that this single molecule, histamine, was the primary driver of severe allergic responses.
But knowing the identity of the chemical weapon doesn't automatically give you a shield against it. I mean, it took nearly 3 decades to find a compound that could counter it.
It did. The real breakthrough on that front came in 1937 at the Pasteur Institute in France.
Right, Daniel Beauvais.
Yeah, a pharmacologist named Daniel Beauvais, alongside his student Anne-Marie Staub. They synthesized a series of compounds that actually successfully protected guinea pigs from lethal injected doses of histamine.
This was such a monumental leap that Beauvais was eventually awarded the Nobel Prize in Physiology or Medicine in 1957.
He was.
But reading through the early trial data, it seems these initial synthetic compounds were a long way from the modern pharmacy aisle. Like, they were considered far too toxic for general human use.
Yeah, the problem with those early molecules was a complete lack of specificity. In pharmacology, we call drugs like that dirty.
Dirty? Why?
Well, they didn't just bind to the histamine receptors, they bound promiscuously to various other receptors, all across the central and peripheral nervous systems.
Which causes problems.
Right, resulting in intolerable and sometimes really dangerous side effects. So the transition from the lab to a safe commercial pill, it required a massive stroke of luck.
And the American twist to this story in 1943 is fascinating. We're at the University of Cincinnati with a chemist named George Reeveshul, and based on his research logs, he is not trying to cure allergies at all.
Not even a little bit.
He is investigating synthetic antispasmodics, which are compounds designed to relax smooth muscle tissue, like in the bronchial tubes.
Which just highlights how much of drug discovery relies on serendipity,
Totally.
Revash synthesized a specific ether compound, and he was aiming for a muscle relaxant effect.
Yeah.
But during the pharmacological screening process, it demonstrated this unprecedented, highly potent antihistaminic activity.
And it was safe.
Yeah, it had a significantly improved safety profile compared to Bavet's early models.
So he accidentally created diphenhydramine,
Exactly.
which was FDA approved just a few years later in 1946 under the brand name Benadryl.
Yep, the classic.
Suddenly, there is a commercially available pill that can intercept an allergic cascade right in its tracks. But to really appreciate the limitations of Benadryl, I think we need to look at what is happening biologically during that cascade, like right before the pill gets to work.
Right. We have to look at mast cell degranulation. Because the allergy process doesn't actually start with histamine, it starts with the immune system making a fundamental categorization error.
Okay, an error. How so?
When you inhale a totally harmless protein, like pollen, your body flags it as a dangerous pathogen, and it synthesizes these highly specific IgE antibodies against it.
And those IgE antibodies then attach themselves to the surface of mast cells, which kind of act as the body's embedded alarm system.
Exactly.
And our biological sources describe these mast cells as being densely packed with tiny granules, almost like a biological piñata.
I love that analogy. Yeah, biological piñata. And those granules are filled to the brim with pre-synthesized inflammatory mediators, predominantly histamine.
So it's just waiting to burst.
Precisely. When you encounter that specific pollen again, the allergen binds to the IgE antibodies on the mast cell, and it cross-links them. This triggers a rapid influx of calcium ions into the mast cell.
And that breaks the piñata.
Yes. It forces all those internal granules to fuse with the cell membrane and undergo exocytosis, basically violently dumping your histamine payload right into the surrounding tissue.
So once that histamine is free-floating, it races toward the H1 receptors. Unless, of course, the inverse agonist, the Benadryl, gets there first, binds to the inactive state of the receptor, and locks it down.
That's the goal.
So the Benadryl handles the peripheral symptoms beautifully, but the side effects are legendary. I mean, anyone who has taken a first-generation antihistamine knows it comes with profound sedation.
Oh, yeah. It knocks you out. And this is where we run into the physiological challenge of the blood-brain barrier. The brain is extremely sensitive to fluctuations in the bloodstream, so it's protected by a tightly packed layer of endothelial cells. And this layer restricts what can cross over from the general circulation into the central nervous system.
I've always conceptualized the blood-brain barrier as a bouncer at a very exclusive VIP nightclub.
That works perfectly.
The bouncer's entire job is to keep circulating toxins and pathogens out on the street. But Benadryl somehow manages to slip right past the velvet rope. Why doesn't the barrier stop it?
It comes down to the drug's molecular properties. First-generation antihistamines, like diphenhydramine, they're highly lipophilic, meaning they are fat-soluble.
Okay, fat-soluble.
And the endothelial cells making up the blood-brain barrier are essentially lipid bilayers. So a highly lipophilic molecule doesn't actually need to be granted access by the bouncer. It just dissolves straight through the biological wall and enters the brain's environment.
And once it's inside the nightclub, we circle back to the fact that histamine is a multi-tool. Because in the nasal tissue, histamine causes inflammation. But our neurological sources point out that inside the brain, histamine is an excitatory neurotransmitter driving the sleep-wake cycle.
Exactly. So when diphenhydramine crosses into the central nervous system, it indiscriminately locks down the H1 receptors in the brain, actively suppressing the histaminergic pathways that promote arousal.
Wow.
You aren't just turning off the inflammatory alarm in your sinuses. You are actively turning off your brain's wakefulness circuitry.
Which explains the severe drowsiness, the impaired motor function, and that heavy cognitive fog.
Right, which is exactly what pushed pharmacologists to develop the second generation of antihistamines.
The loratadines and cetirizines of the world, known as Claritin and Zyrtec.
Yep. The goal was obviously to block the peripheral H1 receptors without affecting the central ones in the brain.
So do these newer drugs just, like, bounce off the blood-brain barrier because they're structurally larger?
That is the first line of defense, yes. Second-generation molecules are engineered to be bulkier, they're more polar, and they're significantly less lipophilic, so they don't dissolve easily through that lipid bilayer.
But they do still get in a little bit.
Sometimes, yeah. But the body's defense mechanisms are highly layered. Even if a small amount of a second-generation drug manages to penetrate the barrier, the brain employs an active backup system called P-glycoprotein efflux pumps.
Okay, the neurological studies in our stack go into incredible detail on these efflux pumps. If the blood-brain barrier is the bouncer at the door, these pumps sound like internal security guards just roaming the floor of the club.
It's a really highly sophisticated cellular mechanism. P-glycoproteins are ATP-dependent transport proteins embedded right in the cell membrane. They essentially act as cellular vacuums.
Vacuums.
Yeah, when they detect these specific foreign molecules inside the endothelial cells, they hydrolyze ATP using the cell's energy currency to physically grab the drug molecule and pump it against the concentration gradient, injecting it straight back into the bloodstream.
So even if the non-drowsy allergy pill sneaks into the brain, the efflux pumps actively throw it back out before it can bind to the central H1 receptors and make you sleepy.
Exactly.
That is remarkable biological engineering. But manipulating these molecular structures doesn't always yield perfect results, right? Because the pharmacological data we reviewed includes some severe missteps in the second generation. Most notably with a drug called diphenhydramine, which was marketed as Seldane.
Yeah, Seldane was a massive blockbuster drug in the 1980s. I mean, it was one of the first highly effective non-sedating antihistamines.
But something went right.
Horribly wrong. Post-market surveillance eventually revealed a terrifying interaction. In a subset of patients, particularly those taking concurrent medications like certain macrolide antibiotics or antifungals, Seldane was triggering fatal cardiac arrhythmias.
I remember reading about this in the sources, but how does an allergy pill designed to target H1 receptors end up causing a fatal heart rhythm?
It basically came down to a metabolic bottleneck and a completely unintended receptor interaction. Seldane was a prodrug, meaning the liver had to metabolize it into its active, safe form.
Okay.
But the antibiotics those patients were taking inhibited the specific liver enzyme responsible for that metabolism. This caused the raw, unmetabolized Seldane to just build up to toxic levels in the blood.
And what did that raw drug do to the heart?
It inadvertently bound to and blocked the HERG potassium channels in the cardiac muscle tissue.
Potassium channels.
Yeah. The heart relies on a very precise electrical cycle of depolarization to contract and repolarization to reset. Potassium channels govern that reset phase.
Oh, okay.
So by blocking them, Seldane delayed the electrical reset of the heart. It's a condition known as QT prolongation. If the heart receives a signal to beat again before it is fully reset, it spirals into a chaotic, often fatal rhythm called torsades de pointe.
Wow.
Yeah, the FDA pulled it from the market entirely in 1997.
It's a stark reminder that we treat these pills so casually, but they really are potent biological modifiers. And that caution isn't just historical, is it? It extends heavily to the older first-generation drugs that are still sitting in our medicine cabinets today.
Very much so.
The contemporary neurological studies we reviewed are raising serious alarms about the long-term use of drugs like Benadryl, specifically regarding something called the anticholinergic burden.
And this stems from the exact same lack of specificity that plagued the early Pasteur Institute drugs.
They're dirty drugs again.
Yep. When diphenhydramine crosses into the brain, it doesn't just lock down H1 receptors. Its molecular structure is similar enough that it also binds to and blocks muscarinic acetylcholine receptors. This is the anticholinergic effect.
And acetylcholine isn't just some minor chemical. It is a critical neurotransmitter for the central nervous system.
It is absolutely fundamental to cognitive function, specifically memory consolidation, learning, and attention.
So by chronically taking a brain-penetrating first-generation antihistamine, you are inadvertently suppressing the very chemical pathways your brain uses to form and retrieve memories.
Exactly.
The observational studies in our stack are honestly sobering. They track cohorts of older adults over many years, and the data suggests a really strong association between a high cumulative anticholinergic burden meaning using these drugs frequently for sleep or allergies over a decade, and a significantly increased risk of developing dementia or Alzheimer's disease.
Now, researchers are careful to note that observational correlation isn't definitive proof of causation, but biological plausibility is incredibly strong.
Because you're blocking acetylcholine.
Right. You are effectively starving the brain's cognitive engine.
Yeah.
And this is why the medical consensus has shifted so rapidly. For chronic daily symptom management, neurologists and allergists overwhelmingly advocate for the second-generation options, which, like we discussed, don't cross the blood-brain barrier and don't carry that anticholinergic risk.
Which brings us to the broader implications of everything we've unpacked today. Because looking at the climate data included in our sources, it's clear the environment is really forcing our hand here.
It is. Global temperature shifts are leading to longer, more aggressive pollen seasons.
Yeah, plants are producing higher volumes of allergens, and they're doing it for more months out of the year.
We are definitely moving past the era where seasonal allergies were just a minor 2-week inconvenience in the spring. For a growing segment of the population, managing systemic inflammation is becoming a year-round requirement.
Which means we are relying on these inverse agonists more than ever before. So to quickly synthesize the journey we've been on, we started by dismantling the cork in the bottle myth, revealing that our allergy pills actually stabilize spontaneously flickering GPCRs.
Yeah.
We realized that our heartburn meds are stealth antihistamines, targeting the H2 receptor neighborhood. And we tracked the chemistry from Dale and Laidlaw's anaphylactic animal models all the way to the accidental discovery of Benadryl, and finally to the brilliant but risky evolution of second-generation drugs utilizing ATP-driven efflux pumps to protect our brains.
It is a really profound look at how intricate the balance of human pharmacology really is. Every single molecular tweak has a cascading physiological consequence.
And synthesizing all of this just leaves me returning to where we started, that thermodynamic flickering of the H1 receptor.
Yeah.
If our environment is fundamentally changing and we are being subjected to unprecedented year-round exposure to extreme pollen levels, it makes me wonder about cellular adaptation.
Oh, that's an interesting thought.
Right. If we are constantly triggering these inflammatory cascades, could our H1 receptors eventually adapt to this new normal? Could chronic extreme environmental exposure actually train those receptors to maintain an even higher, more aggressive baseline of constitutive activity?
Look, they're permanently dialed up.
Exactly. And if human biology does escalate its basal tone in response to the climate, will locking the receptors with our current inverse agonists even be enough? Or are we inevitably moving toward a future where we need a completely novel third pharmacological paradigm to handle the environment we're creating?
Well, it's the ultimate question of biological adaptation, isn't it? Our environment is exerting new evolutionary pressures, and our immune systems are bound to respond somehow.
The science never truly settles. We'll definitely be keeping a close eye on where the pharmacological research heads next.